I've called this meeting the Men's Health Challenge because speaking as a doctor, when it comes to health, men are a challenge. I'm not sure whether police officers and police staff are any worse or any better than average. Maybe we could debate that point. But there's no doubt, so my experience over many years as being a clinician is that getting people to talk about their health, and we've heard examples of this already this morning, it can be a real challenge. So what I want to do is really just explore that a bit more, but also just look at some of the health issues that perhaps we should be thinking about. So this talk's going to be a slight deviation away from the kind of personal talks that we've heard so far, which have been really powerful. But hopefully it's meaningful to people. I'm not a police officer. I am a member of police staff. I am a man, so hopefully 2 out of 3 ain't bad in terms of credibility. So just to give you an overview about what I want to say over the next sort of 15 minutes is, let's just look at when we talk about health and well-being, what actually are we talking about? And then why are we talking about men's health? The point's been made earlier, I think, that we've been doing a huge amount of work looking at women's health, and I think that's absolutely fantastic. But I think it's really important that we talk about men's health for some of the reasons that we've already alluded to. I don't see this as a zero-sum game. This is about doing the best for everybody, because we want everybody to be really healthy. So I want to explore a little bit more about health beliefs. I want to touch on what the statistics actually tell us in terms of the sort of global burden of disease, particularly for the UK and particularly for men. And then I'll just finish to share with you some of the things that we've been doing through the Oscar Keeler website, the National Police Wellbeing Service. These resources are available for people. So, academic bit. What do we mean by health? This is what the World Health Organization talks about health as being a state of complete physical, mental and social well-being, and not just the absence of disease or infirmity. And I think that's really important, because if we go back in time, many of us, I think, in healthcare have taken a very kind of biomedical model. It's all about the diagnosis of disease, the treatment of disease. We've been less effective in terms of going upstream from that and looking at health promotion and prevention, because actually what we really want are people who don't have disease and actually are feeling really good. I've also included another little bit from the World Health Organization's constitution, which says that informed opinion and active cooperation on the part of the public are of the utmost importance in the improvement of health of the people. And the reason I put that in is because from a healthcare perspective, we can't be an ivory tower. We can only be successful if we work with the public that we're trying to help. And so informed opinion and active cooperation are really, really important. And I'm going to talk about this a little bit more when I talk about sort of health belief model. And we can contrast that definition with a definition of well-being, which also comes from the WHO, as a positive state experienced by individuals and societies. Similar to health, it's a resource for daily life determined by social, economic and environmental conditions. It encompasses quality of life and the ability of people and societies to contribute to the world with a sense of meaning and purpose. And that resonates with me. Well-being is a core capability, whether it's as an individual, whether it's as an organization, as a police force. And this thing about being able to contribute with a sense of meaning and purpose, I think, really resonated from me. To thinking about the conversations I've had with people in my clinic when I was Chief Medical Officer for Devon and Cornwall, the number of people who told me that they came into policing because they wanted to make a difference. And I want to just move on to this. This is from Men's Health, the magazine Men's Health, because you start to think about, well, when we talk about men's health, when we try to conceptualize it, what are we actually talking about? And this kind of hit me between the eyes, really, in terms of it's a very sort of macho approach to men's health. So I've just taken a screenshot from one of their episodes, and you can see here that we've got a whole lot of pictures of people in the gym, people who are bodybuilding, people who are building strength. And it's interesting that our first speaker spoke about strength. So as a young man, I'm sorry, I've forgotten the name. Spoke about being strong, and that was physically strong. And it was only in later life that emotional strength and emotional intelligence came to the fore. But I do get this because I think part of what we're about is how do we engage with men, and it may be for at least some men that this is the hook that draws people in. When I was at Devon and Cornwall, we eventually rolled out 34 gyms across our force, and we were really proud of that. Driven very much by our former PTI Sammy Spall, who some of you may know the name. He was absolutely passionate about this. But when we were taking forward our well-being agenda, we made it very clear that this was not just about gym bunnies. So just looking at the bottom of the magazine, you can see that these are the hooks that bring the people in to buy this magazine. It's gym wear, fitness, cardio exercises. Interestingly, it's got mental strength in there. It's got something about nutrition. It's got stuff about style and grooming. So there's some lifestyle issues as well. And it was quite nice to see that they're moving away a little bit from the bodybuilding fitness thing. And there's an article here about, can I train my body to need less sleep? We asked a sleep neuroscientist. And that was fantastic from me and from a National Police Wellbeing Service point of view, because we are very, very keen on, and we've been rolling out live services around the whole sleep fatigue issue, because we know from the surveys that we've carried out that this is probably the number one, if not the top three issue that we have to deal with. And then I went to look at what they were talking about when it came to stress. And this was quite interesting, really. Again, there's the sort of physical fitness side of it. But there's an article here about Ben Chilwell addressing stigma around mental health. And I thought that was quite a good way in, really, because clearly professional footballers are important role models. And to have someone like this talking about stigma around mental health, I thought was a very good way in. Also interesting that they had a feature on, could acupuncture could be used to treat coronavirus. I didn't actually read that, but I just thought it was interesting that they're sort of bringing in the idea of alternative therapies, whether that is a legitimate thing or not. I just want to move on quickly now to talk about some health statistics, which will help just frame the health conversations that we should be thinking about. So three terms just for definition. So one is years of life lost due to premature mortality. So this is looking at the occurrence of health conditions which lead to death, and then comparing that with the expected life expectancy for the UK, which is currently about 86 years. The second one is years lived with disability. So this is looking at the number of years that people have a condition multiplied by a factor that looks at the severity of that condition. And then finally, we've got disability adjusted life years, which is a sum of the two. So if we look at years of life lost for men in the UK, and you can see this table also includes England, Scotland, Wales and Northern Ireland. You can see that the top cause of loss of years is ischemic heart disease. And then that's followed by carcinoma of the trachea, bronchus and lung cancer, or we can just call it lung cancer for short. Then we have what they call self-harm. And I think if we're talking about years lost, we're talking about suicide. Then we have strokes, and then we have respiratory disease, then we have liver disease, and we have lower respiratory infections. We have cancers again, colon, rectum, prostate cancer, and then of course we've got Alzheimer's disease and other dementia and other dementias. So I think this is important just to bear in mind, because I know much of the conversation that we have is around mental health and certainly suicide. And again, our first speaker talked about the driver for setting up the Men's Health Forum in Thames Valley Police. And we also talk a lot about cancer, and cancer is obviously very, very important. But I think it's important that we don't lose sight of the fact that there are other health issues that we should be talking about. Things like cirrhosis, for example, a number of causes of cirrhosis, but clearly alcohol is an important one. So let's talk about cancer a little bit. And I've just noticed a deliberate spelling mistake there. So this is from cancer research. Lots of cancer deaths in the UK every year. Slightly more cancers in men than in women, certainly 2017, 2019. And so a kind of soundbite every 4 minutes, someone in the UK dies from cancer. And I think the thing about cancer is, and why we take it, we really notice it, is that we almost see it as a homogeneous entity, and we add the deaths from cancer together, and that's very powerful. So if you add the important causes of cancer, lung, bowel, breast, and prostate together, that amounts to about half of the deaths in the UK. Lung cancer is very important, and we know that the link with smoking, and it's still sadly a very important cancer for both men and for women. So this is about living with disability. So this is different from the conditions that kill us. These are the conditions that make life miserable for us. And again, here you can see that going from top to bottom, we've got low back and neck pain. Interesting, we've got skin and subcutaneous diseases, and here we're talking about eczema, dermatitis, psoriasis, and other conditions. Problems with the sense organs, and obviously we're talking about hearing and seeing in the main. Then we have depressive disorders, migraine, falls, drug use disorders, oral disorders, asthma, anxiety disorders. Bear in mind that this is for all ages. This is not just for people of working age. And then if we add the two together, this is the disability adjusted life year. So this is the combination of deaths and disability. And here we have, and this is for men, here we are back to ischemic heart disease. Then we have low back and neck pain, skin diseases, lung cancer, sense organs, etc., etc. You can see it there. So I think we need to bear this in mind when I think strategically we're thinking about where we should be targeting resources. I think there's something about, going back to the Men's Health magazine, there's something about what are the hooks that draw people in, and I think that's really important. But let's not lose sight of the main causes of morbidity and mortality. This breaks it down into ages. So you can see that for 15 to 49, which is probably for most relevant in terms of people who are serving as police officers, a little less so for police staff. You can see that low back and neck pain is the number one issue here, followed by skin disease, followed by depressive disorders, then migraine, then drug use disorders. And then as we get a bit older, 50 to 69, again, we have low back and neck pain, then we have the sense organs, then we have oral disorders, then skin diseases, and then we have depressive disorders. And then we can go to a higher age range. And I think something we need to remember here is, yes, we need to be looking at what affects our lives when we're at work, but we also want to take steps to make sure that we enjoy a healthy life once we stop working. Because as I said earlier, the life expectancy in the UK now, if we're lucky, is 86 years. So we want to have 86 quality years if possible. And then these are the risk factors for years of lives lost. So this is very sort of public health orientated, and you will know these things, but I think it's important that we actually see it. So in terms of the most important issues that we need to address: smoking, dietary risks, high blood pressure, and obesity. Of those, I think we're making good inroads in terms of tobacco and people smoking. I think the jury's still out in terms of dietary risks. Clearly progress has been made, but I think there's still an awful lot more to be done in terms of encouraging people to eat healthily. High blood pressure, quite a lot of success there in controlling this. But body mass index, all the stats are telling us that we're getting fatter, and so there's clearly something that we need to be doing there. And then we've got things like cholesterol, occupational risks, and clearly we could talk about that from a policing perspective, plasma glucose, air pollution, and physical activity. So I'm coming towards the end now, but I just wanted to sort of share this with you. This is a model about health beliefs and how we can change behavior. It's called the Stages of Change model by Prochaska and Di Clemente. And this was first put forward in relation to cigarette smoking and trying to get people to stop cigarette smoking. It could perhaps also apply to what we've been talking about with addictions, but I think it's relevant to a whole host of things, really. I think particularly when it comes to men, because the first stage is what they call pre-contemplation. And you can see that this is no intention of changing behavior. It might even be at that stage that the people are completely unaware that there are any issues to do with their health. So one of the challenges is to raise awareness, and to get people to a situation where at least they might start to think about the need to make a change. So this is where we move across to contemplation. But even at that stage, there's no commitment to action. So what do we have to do to move people from contemplation to preparation? And at that stage, there is an intent to take action, but we have to equip people and make it possible to happen. That then takes us on to the action. So whatever that action is, the people have got a belief that they can do it. There's what we call self-efficacy. They've got the tools to do that. Then we need to maintain that change, and I think this is where it's important in terms of things like cigarette smoking and perhaps rehabilitation from addiction, because we don't want people to relapse. And for me, this is about not only about having some kind of safety plan for individuals, but it brings into focus the influence that other people can have in trying to maintain that. So there's something about the social context of this, and the norms, and that could be the culture of a police force, but it might also be the culture of the society that people are living in. So what we want to do is stop that relapse. So just thinking about that model, from the National Police Wellbeing Service perspective, we have made available now a number of resources. You can see them there. We've done an awful lot of work on cancer and prevention, an awful lot on healthy living. I've mentioned the focus on sleep already. A lot of information about nutrition and physical health. When we first started out, mental health was our main focus, and probably it still is, to be fair. So a lot of work around psychological and trauma risk management, suicide prevention and postvention. You'll be aware of Operation Hampshire, which is looking at the assaults on police officers. And we've also taken some initiative to try and get out there. So we have commissioned a fleet of vans that can take wellbeing out to the front line. And more recently, we've got the Wellbeing Dogs, the OK9 initiative, which is proving to be very popular and is a way, I think, of breaking the ice and starting to get people to talk about issues. So just thinking about that change model, this, I think, is about that precognition going to cognition phase. Where we need help is for examples like the Men's Health Forum that we've heard about already, perhaps peer support, the peer support initiative that we've been pushing as well, because I think it's about how we get people to believe that they can make changes, so they can do something practical. They can do it. They will be supported by colleagues. There will be role modelers out there in the forces to encourage it. And the culture of the force will be such that it not only encourages people to make healthy changes and healthy choices, but it will help people falling back, that kind of relapse element, falling back into unhealthy behaviours. So I'm going to stop at that point. I hope that's been helpful, and I look forward to the Q&A at the end.